Hello, I'm Andrew Susskind, and I'm a therapist and author based on the west side of Los Angeles since 1992, specializing in trauma and addictions. Welcome to my podcast, named after my recent book, It's Not About the Sex. Here we have honest conversations related to compulsive sexual behavior and trauma, all from a sexual health perspective. Our intention is to offer fresh viewpoints and practical strategies toward establishing greater intimacy and a more deeply connected life. Let's begin. Dr. Mel Pohl is a family practitioner, and he's also the senior medical consultant of the pain recovery program at the Pointe Malibu Recovery Center. He is certified by the American Board of Addiction Medicine and is a clinical assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Nevada School of Medicine. Mel is also the author of two books, A Day Without Pain, Revised Edition, Central Recovery Press, 2011, and The Pain Antidote, Stop Suffering from Chronic Pain, Avoid Addiction to Painkillers, and Reclaim Your Life, DeCapo, 2015. Dr. Pohl also filmed a show for PBS on chronic pain, which aired around the country in 2016. And on a personal note, I just wanted to share how I met Mel. We were at the Evolution of Addiction conference, I want to say 2011. I'm not sure the exact year, but I heard Mel speak and I thought, wow, this guy really knows what he's talking about. And not only in terms of content, but just how he delivered the information was so palpable, how he knew everything that he was sharing, but also that he knew his audience. And that for those of us who didn't have a lot of background with understanding chronic pain and addiction, he made it easy to understand. And for that, I feel like he really laid the groundwork for my own understanding. So welcome all. It's so great to have you here today.
Yeah, thanks. That's very kind words, and it's great to be here, Andrew.
Yeah, and I'm especially excited about this particular podcast because we haven't talked about chronic pain here, and because it's so pervasive and it's something that is so misunderstood in a lot of ways. I think this is a great opportunity to have an honest conversation about how to look at this from a clinical viewpoint, but how to help our clients understand, our patients understand better how to approach this, whether it's in their own lives or the lives of loved ones. So the first question is a very important one. So what is the difference between acute pain and chronic pain?
So, a great question. The pain is a functional process. It's purposeful. We injure ourselves, we feel the pain signal, and we take action in response to that feeling so that we protect the injured tissue. So if I sprain my ankle, I don't walk on it. The pain signal, the purpose of that pain signal is to say something's wrong, pay attention to that area. There's inflammation around the injury, and eventually, if it's acute pain, the signal will end when the tissue heals, and the tissue will heal because it's acute. Acute means it'll be time limited, purposeful time limited. So, and think about acute pain as the purpose for pain that God created, that the nervous system created. It's a protective function in our nervous system. Chronic pain is an entirely different process. The only thing, in fact, in common between acute pain and chronic pain is that word pain. If you look at the etiology of chronic pain, rather than purposeful, it is not purposeful. So people who have headaches, what's the purpose of a headache? We might, get into the psychological purpose. If I have a headache, I can't work, so then I get to take time off. But that's a whole complex issue that we could approach down the line. But really, it's not telling me something's wrong and I have to do something about it. It's telling me I don't feel well, and what happens? I get frustrated, I get angry, I get irritable, I get depressed. it's unending. There's no end in sight to the chronic pain condition. And even though there may be periods of remission and exacerbation, it's a lifelong condition, whether it's fibromyalgia or chronic disc disease or headaches, as I mentioned, or complex regional pain syndrome. And the real key, Andrew, that differentiates acute pain from chronic pain is that it is not related to tissue damage. The mind says, oh, there must be some reason, there must be some cause in my body that is making this pain hurt, when in actual fact, it's the brain itself that is misfiring. It's a miscommunication. It's misreading of the signals that come from the body and cause an interpretation that something is really out of whack and I have to do something about it, when in fact, that's not the truth. So there's a chronic misunderstanding. And, this is across the board. It's clinicians, it's family members, it's physicians, and it's patients. So a different process. We, in the medical profession, have done a disservice to patients in that we treat chronic pain like it's just more of the same. So it's an acute condition, tissue related, that just continues on in an unending basis. So what do we do for it? Well, we x-ray it and we inject it, and we eventually do the worst thing in the world, which is to operate on a spine that's got a little bit of a disc bulge. We attribute the pain to the disc bulge. We put titanium rods in the spine in a fusion procedure, and the chance of that really working is very, very slim.
So in other words, and I would say that this happens with chronic pain and with addiction on a separate track, that a lot of clinicians, including doctors, of course, are not necessarily well trained in these areas. And so they do the best they can, but there's oftentimes, like you said, there's different types of treatment or interventions that really aren't the best choice. And I'm wondering if you can maybe share a little bit more specifically about how the medical profession just doesn't always get it right.
Yeah. Well, I'd where do I start? I mean, I guess I would
Yeah.
begin with the basic premise that most physicians, most clinical practitioners of the medical sciences are not well trained in listening. So, we go in with some sort of a predisposition belief that, I got to find what's wrong with you. When I went to medical school, I remember it was like I had this thing in my pocket, like a weapon, and it was actually a prescription pad. And I could whip it out, and I could give you an antibiotic, and I could give you a decongestant, and I could make a diagnosis and send it into the insurance company. That really didn't have much to do with what you were telling me when you came to see me. And if I'm not really listening and attuned to what the patient is saying, we really miss the boat. The other thing is that when somebody comes in, it tends to make us as clinicians, but certainly as physicians, very uncomfortable, because we honestly don't know what to do. Chronic pain it's just, there's so much suffering associated with chronic pain, and we're just not equipped. We don't have the time, we don't have the energy. And again, we have several tools. We have needles if we're anesthesiologists, pain doctors. We have knives if we're surgeons, and we have prescription pads for everybody else. And all too often, the easy, direct, and popular thing to do is I give you a prescription. And if what I give you doesn't work, when you come back, I give you something stronger. And that's the way we proceed.
Wow. So I think what I'm hearing is that there's sometimes, maybe a lot of the time, a lack of humility when it comes to not knowing.
Well, I guess you've nailed that one. You must be a therapist. Yeah, it is. It's I don't ascribe motivation. I think really it comes from an insecurity or an inability to really be helpful. Because, in the medical model of sort of Western medicine, it's make a diagnosis and give a prescription, and fix what's wrong. Well, when we're really looking at chronic pain, we're looking at brain misinterpretation, and there is no simple, easy answer to what to do about that.
Sure.
It's much more complicated. So in my inadequacy, I do the best I can with what I've got, and it's a 10 or 15-minute appointment. This is an hour-long conversation.
Sure.
So and some docs get it, they understand their limitations, and some really just don't.
Sure. So, of course, as part of this conversation, the idea of considering opioids is part of what goes on out there. How can you, as a physician, justify withholding opioids from people who are suffering with chronic pain?
Sure. So opioids, of course, narcotics like hydrocodone or oxycodone or morphine or methadone or fentanyl. I mean, there's probably hundreds out there, but certainly tens and 20s of these different prescriptions are potent painkillers, and they are appropriate. Actually, the only time they're really appropriate is for acute pain, because the use is time limited. They are effective to diminish the pain signal. And the CDC put out guidelines in 2016, and they've been pretty well challenged, and they're battering them around right now. But one of the fundamentals was, if you're treating acute pain, do it for a really short time, 3 to 7 days worth of a prescription. Don't give a month's supply of anything. So what about the person with chronic pain? Well, when we set the stage, that person's going to have a lifetime of this condition. So do we want to commit that person to take a lifetime of opioids? What happens over the course of time, long-term with opioids, is several things. One is tolerance develops. So that means they don't work as well. So the next step is to increase the dose, because the body accommodates to the opioid presence. Tolerance means you got to have a higher dose to get an effect. And then, of course, physical dependence occurs. So that means I can't live without them. So now my body has become so used to this drug that I'm normal with it, I'm abnormal without it. And then if we're going to use opioids for chronic pain, it ought to be, let's do it for a month, see how it goes. And chances are by the first or second week, the benefit is achieved, limited, and then it starts to diminish. There's a choice point there. What do? Do I increase the dose, which is what typically I'll do, or do I say, you know what, the trial, it's not like you're taking one every 2 or 3 or 4 days. You're taking 3 a day, and now you're telling me they don't work. So we could go to 4 a day or double the dose, or we could say this is not a good trial with this, and we should exit before we get down the road with you on high doses of opioids and less efficacy for your pain. The last thing to say is that opioids are actually what we call pro-inflammatory. So we've learned over the course of time that opioids cause more pain in the long run.
Wow.
They inflame certain areas of the brain. They cause certain support cells to become activated. They cause the secretion of inflammatory chemicals. And the net effect is that the person has more pain on the opioid than off. I have a patient in treatment right now, and she was on 1,000 milligrams of morphine equivalent a day. That's 60 milligrams of methadone, 75 micrograms of fentanyl every 3 days in a patch form, and 150 milligrams of oxycodone a day. That's a ton. I mean, I've been doing this for 40 years, and that's really a high dose. She came off her opioids, and her pain and she had very severe back pain for 6 years. Off the opioids, she's not in pain.
Wow.
She has no pain. So how can we explain that? Well, the inadvertently, she and her physician got caught in this conundrum of higher dose, higher dose,
Mm.
higher dose, higher
Mm-hmm.
dose. And, we misunderstood the signal of, no, really the chronic pain was related to a whole lot of other issues that were not properly treated with opioids.
Mm. The statement that you made about opioids being pro-inflammatory and how counterproductive they truly are is astounding, because I didn't know that, and I imagine
Mm,
that most people, most clinicians, don't realize that.
yeah.
But it's so important to understand, and I'm glad we're shifting into some more optimistic questions to focus on, because what you bring to the table is truly something refreshing and an alternative that
Mhm.
that I don't know, maybe you can speak to this now or at another point, but I'm not sure why it's not more widely understood.
It's a very astute question. Um, I think it really underscores some of the things we've already talked about, which is that the system is built for disease and pathology and
Mhm.
prescriptive measures. So successful treatment of a patient is writing the
Mhm.
prescription and getting him or her out of your office in
Mm.
10 minutes so you can see the next patient. It's not really making the connection that you and I know is most important in
Mhm.
really touching people and communicating with people. And it
Mm.
turns out diminishing suffering from chronic pain. So, it needs a system overhaul. And
Sure.
I don't know if we're in store for that. I mean, the other thing is that doctors are incentivized for doing things that cost money, that make them money. Not to say
Mhm.
they're doing it to get
Mhm.
rich, but it's a subtle uh, but pretty dysfunctional system.
Yeah.
And there's talk of shifting that.
Mhm.
Medicare shifted their perspective to, let's look at outcome measures. How we assess patients by what their pain score is. Their pain score is high, we up the dose of medication. We ought to be assessing them not on what's the matter, but what matters to you. How's your life?
Mm.
Where do you go? Do you have joy in your life? Are you having
Mm.
fun? Are you able to hang out with your grandkids? No, I'm in bed all day. The only thing that gives me respite is medication for an hour or two. That's a terrible way to live.
Yeah. I could talk all day about what we're hitting on now,
Yeah.
but I really want to hear about what works. So tell us more about what are the effective measures to treat
Yeah.
chronic pain.
Yeah. So I'm not a youngster. I've been in the field for over 40 years. I thought I'd be winding down, and I got to this job offer at the Pointe Malibu Recovery Center. And as you know, Malibu is it's just a lovely place to go and hang out. So we have this really excellent team-based approach to chronic pain. We call it pain recovery as opposed to pain management. And it's really about how do you find the quality in your life and
Mhm.
the relief from the suffering. And it's really based on some of the premises that we've already touched on. The first is to acknowledge that the pain is real and really pay very exquisitely close attention to the story that the patient has to tell. And
Mhm.
then to really begin to look at what the story is based on. And more often than not, the story of chronic pain is based in fear. Fear that it's going to get worse, fear that I'm going to become disabled, fear that if I move, it will hurt. So I don't move. It's called fear avoidance or kinesiophobia, phobia of movement.
Mm.
And before you know it, the fear is driving the pain. So
Mhm.
instead of the pain causing the fear causes the pain. And what's associated with fear is anxiety and activation of the nervous system. So the core elements of our pain recovery program are to help the patient see the truth, which is the tissue is not the issue. The issue is your brain. And
Mhm.
then to teach them, in the time that we have with them, measures to turn down the volume inside the middle part of the brain, which of course is where the drugs work. So, the drugs temporarily turn it down, but in the long run, it ratchet it up. But the problem is that this middle part of the brain where emotions are lodged and where pain exists, the volume's turned up inside that part of the brain. So measures that work to turn down the volume are really the essence of pain recovery. And, we use breathing techniques, and we use mindfulness practice, and we use polyvagal theory to help people co-regulate, by being around other people and diffuse some of the seriousness of their own condition. We use a process called pain reprocessing therapy, which is this really cool science that's been developed by Alan Gordon at USC. He's in the pain, I forget what it's, I think it's pain reprocessing therapy. But anyway, they wrote an article in the Journal of the American Medical Association. So this is a controlled study of their method. And the method is essentially, it's a pretty complex process, but it's really all helping the brain correct the misinterpretation in many different ways, so that the focus is really on my beliefs and my fears and not on my body, and really reappraising and helping people somatically experience the fact that I'm perfectly safe. I personally have chronic back pain, but I can sit here and talk for hours, and I can go for a walk with my dog, and I can go to the gym, and I can lift weights, and I can hike, and I could even stand on my head, but it makes me dizzy, so I don't do that.
That's where you draw the line.
Yes, but it's not a functional, meaningful pain. It's just, it's my brain's interpretation that I saw my MRI. I have a bulging disc. I can feel where the bulging disc is. Well, that's not the case, because the same bulging disc exists when I'm lifting weights and I don't feel the pain. The same bulging disc exists when I'm at a concert and I don't feel the pain. The same bulging disc exists when I'm walking in the flower fields and I don't have the pain. So how can I explain that the physiology of my body is causing the pain? I can't. And as you begin to unravel that, and there's a lot of skill involved, as you can imagine, in this clinical technique, but as you begin to unravel that, and the study that I briefly mentioned is that over the course of 6 weeks, people came to the study with an average of 11 years of back pain. So these were chronic pain sufferers. It was done in Boulder, Colorado, and they divided the groups into pain reprocessing therapy, control group, and what they call treatment as usual, which was some physical therapy and some cognitive behavioral therapy. With pain reprocessing therapy, pain scores dropped from like an average of 3.8 out of 5 to less than 1 in 6 weeks. And those benefits were sustained over the course of a year. And furthermore, they did functional MRI scans of the brain, so they could actually see the brain before this treatment and after the treatment. And the brain changed. The areas of the brain where pain is interpreted diminished in their signal on the functional MRI. So, it proved that we can actually treat chronic pain with psycho-behavioral measures very effectively. And they're disseminating this message. Is it going to change the way the mainstream believes? I don't have great optimism about that. But there are some really wonderful tools to deal with the nervous system issues.
Sure. And even if it helps one person at a time, I think what you're saying over and over today is that as much as we know, we're learning all the time. And that's really cutting edge kind of approaches that you're describing. And hopefully down the road, we'll be having different conversations that today, what's cutting edge won't be so cutting edge at some point.
Yeah, I totally agree. And again, the biggest cutting edges don't look for a tissue solution to the problem. Look for a brain solution, and talk to your patients. For listeners, if you have chronic pain or if you're working with a chronic pain patient, pay close attention to the story, and then begin the process of walking people away from the certainty that, the people will identify a precursor to their pain that really has nothing to do with their pain. So I was in a car accident. 3 days later, my neck started to hurt. Well, there's no logic to that. That's what a whiplash injury ends up looking like. In Lithuania, they don't have the term whiplash in their vocabulary, and they have zero cases of whiplash. So, it's the expectation causes the outcome. We have powerful minds.
Right. And just for perspective, I want to add that when I was in grad school, we didn't talk about the brain or the nervous system. And here we are in 2022, and we know that it has to be the focal point of healing. Yeah. And so everything you're saying is just very significant in profound ways.
Yeah. Yeah. Pain neuroscience has come leaps and bounds. I mean, I have a network of colleagues who are doing this work and talking about this work and creating miracles, among patients, where people who've suffered for years are out of pain and living their life. I've seen it over and over and over again. So it can be done, and it takes work, it takes energy, expenditure, but it's pretty remarkable. And yeah, it's all based in the brain.
So how would you say pain or chronic pain is similar to chemical and process addictions?
Well, there's an interesting study. Is done on a functional MRI at Northwestern University. The principal investigator is a guy named Ebkarian. He's very colorful. I think he's Romanian, Vanya Ebkarian. And essentially what he did was he did functional MRI scans of people with acute pain, so back pain less than 6 weeks. And then he did functional MRI scans of people with chronic pain more than 6 months. The functional MRI scans of the acute pain showed a particular part of the brain, the thalamus, lit up. And the thalamus is kind of the basic relay station of the pain signal that functions in the acute pain signal. With chronic pain, they described it as a different signature, and it was areas of the brain, particularly, and I'll say big words and hopefully some people recognize them, but the nucleus accumbens and ventral tegmental area. And these are two areas where reward is exhibited and drive are established. And guess what works in those areas? Substances and process. That's what dopamine is doing its deal. So chronic pain looks a lot like addiction. And if you look at the behavioral phenomena in chronic pain, what we see people who they're almost addicted to the preoccupation with the pain. So they're driven to pain becomes the identity, just like the substance or the behavior becomes the focus of a person's activities, even though it's not serving their ultimate well-being. It's the almost compulsive drive to do something about the pain. I mean, a lot of patients that I see have been to doctor after doctor after doctor, clinic after clinic. So it's not uncommon to see people feel relatively hopeless that this time it's going to be different and this time it's really going to work. So there is a biochemical similarity and a behavioral similarity between chronic pain and addiction.
So just to illustrate, let's say someone does go from doctor to doctor to doctor, and they're getting lots of different prescriptions and have that desperation in their seeking. How would you distinguish that person from someone who falls more cleanly into an addiction kind of category or addiction kind of cycle? Or are they overlapping?
Well, that was what I was going to say, is they are overlapping. What's interesting, if we look at chemical use, people who use opioids, who have prescriptions for opioids and take them as prescribed, often end up in my clinic. And the reason is that the reward center and the relief center, are sort of inextricably linked. So I take my meds because I'm in pain. I want to be out of pain. Well, most of my alcoholics drink to get away from the horrible consequences of their drinking.
Right.
So the pathological pursuit of relief, which is what people with chronic pain end up doing with their medications, is still addiction. You know, it meets the criteria from the DSM. If we sit back and look at behaviors, or if we put that person into an addiction group or into a 12-step program without, you know, some understanding, it's a mismatch, and they will not feel comfortable there. And that's often the case. On the other hand, with proper psychoeducation and support, those people can find a home sometimes in the 12-step programs or in a support group for people who have substance use issues. So, you know, subtle differences in that case.
Right. So in other words, it's really a matter of understanding the person and their complexities. It's not a one size fits all.
Oh, no, absolutely not. I mean, the model is one that has some commonalities to it, but the individual nature of, because, you know, we haven't even touched on the fact that people come with a story. Well, the story starts in childhood. So most of the people, 80 to 90% of the patients that I treat with chronic pain have serious trauma histories. And you know, it can be sexual, emotional, physical trauma, or it can be medical trauma. These are people that have been really traumatized by our system. You know, they go to the surgeon operates, they come back to the surgeon with the same and worse symptoms, and the surgeon says, I don't know what to tell you. I did my job. It must be in your head. Must not be real. You know, well, the cost of that disbelief is just astronomical.
Sure. So before we wind down, I'm wondering if you were to share one or two takeaways that you would like our listeners to really hone in on, what would they be?
The first one would be to get curious about the process of chronic pain. You know, just some of the things that we've touched on today, you know, without dismissing them out of hand. No, he's crazy. I got disc disease. You know, I have degenerative disc disease. Be curious about what story you've developed in your mind, or your client or your patient has developed in his or her mind, that drives the experience of pain. And then become curious. The next would be to notice what comes up around that. And the things that are going to come up are fear and anxiety and worry, you know, that it's going to get worse. And then begin the process of taking that apart. Now, all of those steps are pretty complicated, but so that's why I say to start, just be curious about this. There's a couple of resources to look at. I mean, you mentioned my book, of course. The book that Alan Gordon wrote is called The Way Out. And it describes in detail the study that I described and the pain reprocessing therapy treatment program that he has. That's The Way Out. And then there are two apps that I refer people to. One is Menda, MENDA. That's the one that we use at the Pointe with our patients. And Curable is the one that Alan Gordon actually set up. And there, you know, you can get access to them for free. And then, of course, there's a charge if you want to do something there. But if you have somebody in your life who has chronic pain, that's a great starting point, because they explain all this in a lot of detail and then move people towards solutions.
Sounds like really, really helpful resources, which of course we can't get enough of, especially with something of this nature.
Yeah. Yeah.
So I just want to thank you so much for being here today. It's always a pleasure speaking with you, and thank you so much for sharing the time.
Great. It went fast. It was great. Thanks. Thanks for the opportunity.
All right. Take good care.
You too. See you.
Thank you. Bye-bye.
Bye.
Thank you for listening today. It was so terrific sharing the time with my colleague and friend, Dr. Mel Pohl, and discussing this really vital topic. If you're so inclined, please give us a 5-star rating and be sure to subscribe and share my podcast with those who may benefit. I look forward to you joining us the next time, and don't forget to stay connected.